all so quiet. You're nervous. Okay. I forgot to mention, you'll need a calculator. If you have a calculator on your phone, just use your phone. Is there anyone who really needs a calculator? We've got some in the office. I can go get some. There's no heat coming out of there. That's why it's so darn cold in here. Next quiz, I'll start over there. That way. Next time we have a quiz, I'll start over there. That way you don't feel left out. Breathe. Where's Grace? It's just me or is she? Oh, okay. They're just late. All right. there any more quizzes out that I haven't picked up yet? No? Okay. See, that wasn't so bad, was it? Okay. So today I want us to talk about drug biotransformation. So that step in pharmacokinetics that we called metabolism, we need to dig a little more deeply into what goes on with drug metabolism, because most of the drug interactions that you'll encounter in your careers, which I hope will be long and illustrious, will be of a pharmacokinetic nature. Did everyone get what I missed? Anyone? Now, who can tell me the main players when it comes to metabolism of drugs in the liver? What are the enzymes that do the big heavy lifting? Cytochrome P450. So your cytochrome P450s they subject the drug to so-called phase 1 modifications. And then your transferases will subject drugs to phase 2 modifications. Usually, phase 1 reactions occur first, followed by phase 2 reactions. There are some exceptions, but that's usually the way that pharmacokinetic cookie crumbles, so to speak. Good exception is acetaminophen, when it goes phase 2 first, then phase 1, so does isoniazid, the anti-tuberculosis drug. Virtually the rest of them want to go phase 1, phase 2. Now, drugs can, let's say this is phase 1 and phase 2. Drugs, let's say drug 1. Drug 1 can be subjected to phase 1 modifications and then phase 2 modifications, and then you have a drug 1 metabolite. That happens, and that's a pretty often scenario. Drug number 2. Drug 2 may undergo a phase 1 modification, and then it may pass go and collect $200, and you might have a drug 2 metabolite. Well, that happens too for some drugs. Then you have drug 3. Drug 3 may just go through phase 2 modifications, not have any interaction with cytochrome P450s at all. And then you have a drug 3 metabolite. And then you have drug 4. And drug 4 may bypass the whole thing and just be excreted as is. And that happens too. So drugs are different when it comes to which of these they participate in. Many of them participate in both. There are some, however, that just do one, not the other. And then there are some that do neither. And there you are. And again, phase 1 reactions typically occur first. Phase 2 typically occurs second, but there are exceptions. Very good. All right, you with me so far? Now, Cytochrome P450s, as we said, constitute a gene family. Humans have 49 different cytochrome P450s. Oh, joy or rapture, aren't you glad? Well, turns out for drug metabolism, there's only a handful that are important. And these are the ones that are on your handout that we will talk about. So cytochrome P450s are called CYP. Then you usually have a number. Then there's a letter followed by another number. And that's how you classify them into their various gene families. So the ones that are important for human medicine are as follows. 1A1, 2C9, 2C19, 2D6, and 3A4. And I'm going to underline that one because this is definitely the major drug metabolizing enzyme in your body, for sure. 1A1, 2C9, 2C19, 2D6, and 3A4. These are all cytochrome P450s, but they're different types of cytochrome P450s. If these were pies, this would be apple pie. This would be raspberry pie. This would be banana cream pie. This would be chocolate cream pie. This would be pumpkin pie. But they're all pie, but they're different types of pies. Because these are the major P450s that metabolize the drugs that not only you might take during your lifetime, but you will give to patients in your lifetime. These are the major ones. Yes, ma'am. These are located in the liver, but some of these are expressed at low levels in the GI tract. 3A4, for example, is expressed in the small intestine, but at a lower level. So the liver is definitely the major organ. However, other organs can play smaller roles as well.
Do all of those originate from the liver and then move their
No, they're inside hepatocytes. In fact, these are located in the endoplasmic reticulum. I know ERTU means emergency room, but it means, in this case, endoplasmic reticulum. They're embedded in the endoplasmic reticulum. That's why, remember in anatomy, did you look at slides of liver? Remember all that stuff in liver that looked a little bit like spaghetti? That's the smooth ER. Liver's full of it because liver is going to process these molecules. And a word that is in your book that you might want to get used to is this term xenobiotic. What's a xenobiotic? That is a substance that your body doesn't normally see. And so cytochrome P450s take xenobiotics, turn them into something that is much more easily disposed of by the urinary system of your body. Morgan, you're scratching your head like you're not too sure about what I said. No? You're good? Yeah? Okay. All right, I want to make sure we're on the same page here. Yes, ma'am? Yes, they're proteins. They're enzymes. In fact, because they're cytochromes, they have a heme group, just like in hemoglobin, with an iron in the center. So guess what? If you have low iron, you're not going to be able to process drugs very well. That'd be a consequence of having some sort of iron problem, or Friedreich's ataxia or something like that. Friedreich's ataxia, sorry. Very good. Let's then look at our handout, please. Yeah. Now, please turn to well, yeah, let's just, okay. Anyway. Now, if we were to look at the substrates of cytochrome P453A4, here's a list, a partial list of substrates of 3A4, all those and all those. So this is the major enzyme for metabolizing drugs. This particular table's not on your handout. Now, some molecules, some drugs inhibit cytochrome P453A4. Others induce it. Let me say that again. Some drugs inhibit cytochrome P453A4. Others induce it. And you have a table on page 2 that shows you the inhibitors of cytochrome P453A4. Now, of those, the ones I want you to put a little star by, the ones that are really, really good at inhibiting 3A4 are clarithromycin, itraconazole, ketoconazole, nifazodone, where did I put that? And then nelfinavir. Oh, and one more. See, says ritonavir. Yeah, put a little mark by that one. Those are kind of the ones that are really good at inhibiting cytochrome P453A4. Anyone on any of those drugs will have markedly reduced levels of cytochrome P453A4. Now, think about this with me. Here's a drug. It's metabolized by 3A4. Now, you inhibit 3A4, what's going to happen to the half-life of that drug? It's going to go up. It's probably even going to accumulate in your body, and you're going to get toxicity. And that is what the table on the front of your handout is meant to illustrate. Morgan? Sorry? Well, sometimes you want to give drugs and they're 3A4 substrates, and one of them happens to be a 3A4 inhibitor. And if you see that, you have to be aware of that. And sometimes patients will come in, they've gotten this prescription from this doctor, this prescription from that doctor, this prescription from that doctor, and they didn't tell the doctors they're on these medicines. But they tell you, because you're the nurse and you're actually spending time with them. Not say doctors don't spend time with them, but the time you're at their bedside and you're saying, okay, let's see what you're on here. You know, I need to know everything you're on. Herbal stuff too. Can you do that for me, please? And then you find out they're on this and this and this. Your first reaction is, they shouldn't be on that together. And so you tell the provider, you might very well save this person's life. So there are programs now you can do this. You can enter in drugs and they will give you this red flashing signal, don't prescribe those together. But essentially, there are certain drugs, if you prescribe them together, you're in deep weeds. All right, so these drugs here, all of those are cytochrome P450 3A4 substrates. And if you give them with a 3A4 inhibitor, these are the consequences. Let's just look at this. Severe hypotension, excessive central nervous system depression. Holy Moses, this doesn't sound good. What do you think? Cushing syndrome. Good gravy. Vomiting, headache, dizziness, drowsiness, definitely not good. Fever, diarrhea, muscle pain, paresthesias, maybe fatal. Holy crumbs. Cardiac arrhythmias, more Cushing syndrome. Torsade de Pointes. What's torsade de Pointes? Torsade de Pointes is French for twisting of the poles. That means that in your heart, what was positive now becomes negative. What was negative now becomes positive. This is a very, very serious arrhythmia that can lead to ventricular AFib. I'll let you read the rest of those. Okay, can we look at these and agree these are bad? Yes? And they're because of a drug-drug interaction that is pharmacokinetic in nature. Okay? Do you understand? All right. And again, this is the major enzyme for drug metabolism. Other drugs induce cytochrome P450 3A4. They increase the activity of cytochrome P450 3A4. Not all cytochrome P450s are inducible. 3A4 is inducible. And the inducers are shown down here. Now the biggie I want you to put a mark next to is rifampin. Rifampin. Rifampin is notorious because if you have a young lady on birth control, many of the estrogens in birth control are metabolized by, you guessed it, cytochrome P450 3A4. Now, think through this with me again. Here's your drug. Here's 3A4. Now, instead of 3A4 doing this, 3A4 is really chewing it up. Now, what's going to happen to this drug? What's the half-life of this drug going to do? You're going to have treatment failure. And so a lady is on birth control. She gets rifampin as a treatment. And then all of a sudden, she discovers that she's pregnant. Her birth control failed because the cytochrome P450 3A4 chewed up all her estrogen and she didn't get any contraception. See how that works? So combining any of these substrates with these drugs here may cause treatment failure. Someone comes to you and says, this drug doesn't work. That might be why. You might want to check the medicines they're on for drug-drug interactions of this nature. Yes?
So what an inducer with an inhibitor, it might be too far out.
Depends on which one was given first, and it depends on the dosage of the two of them. Now, if you have an inducer, sometimes what you can do is you can just up the dose of the drug that is a substrate, and then you'll actually get proper treatment. So there's that strategy that you can use. For example, HIV patients who are on protease inhibitors, you'll notice protease inhibitors are some rather notorious inhibitors. So this actually happened at a prison in Sacramento, California. There was a prisoner who was HIV positive, but then he got coccidioidomycosis, respiratory coccidioidomycosis. They had to treat him, but because he's being treated with an inhibitor, they took the dose and they cut the dose in half, and it was still effective because the drug wasn't being chewed up by 3A4 quite so much because of the inhibitor, and the drug actually was able to treat the systemic fungal infection. So there's different strategies to this. This is just one particular enzyme, but it's the major one. And so interactions, a lot of them tend to be around 3A4. All right, questions? If you put someone on a drug that's a 3A4 inducer and you give them another 3A4 substrate, you will have up to 90% reduction in the serum concentration of that substrate. That's pretty significant. Very good. Okay, if you look now at page 3, let's talk about cytochrome P450 2D6. 2D6. Now, 2D6 is an enzyme that shows lots of genetic variability. There are some people who don't have any cytochrome P450 2D6 activity. So it's about 6 to 10% of Caucasians, 3 to 6% of Mexican Americans, 2 to 5% of African Americans, and about 1% of Asians. So it's spread throughout different ethnic lineages. But these folks are so-called poor metabolizers. They don't have any detectable cytochrome P450 2D6 activity. There are others who have low activity. Low activity. The rates of low activity have not yet been established by research. But these folks have 2D6 activity. It's just slow going. The majority of people have so-called normal 2D6 activity. But then there are some who have a gene duplication of the 2D6 gene. They have multiple copies of it. And they are so-called ultra-rapid metabolizers. Ultra-rapid metabolizers. So this is 1% of Finnish and Danish people, 4% of Caucasian North Americans, 10% of Greeks, 10% of Portuguese, 20% of people of Arab extraction, and 30% of Ethiopians. That's pretty significant when a third of Ethiopians and Northern Africans in general are ultra-rapid metabolizers. So, what sorts of drugs are metabolized by 2D6. You don't have a list of substrates, but I'll just tell you a few to be aware of. Proton pump inhibitors tend to be metabolized by 2D6. In fact, proton pump inhibitors are prodrugs. They're activated by 2D6. So if you have someone who has no 2D6 activity, a proton pump inhibitor is going to work for that patient? No, because the drug will not be activated. It's a prodrug. It needs to be activated. Other drugs that are prodrugs include codeine. Codeine is activated to morphine by cytochrome P450 2D6. What happens if you give an ultra rapid metabolizer morphine, a codeine? You might get morphine poisoning. In fact, there's a case study of a mother who was breastfeeding her baby. She was taking codeine for pain because she had a C-section. She was very, very vigilant to make sure that her feedings and when she took the drug were spaced apart. But because she was an ultra rapid metabolizer, her body made so much morphine, she actually morphine poisoned her baby to death. So sometimes genetic tests for these sorts of things might actually be important. And the prices of these tests have actually come down quite a bit. So now you can order them and actually know if someone's going to have this sort of issue. Now, yes?
Why do 30% of Ethiopians have that? Is that like environmental?
I can make a good guess. You want me to? You ever eaten Ethiopian food?
Yes.
Delicious, isn't it? They use spices from plants that grow in their very, very alkaline soil. Those spices are full of plant alkaloids, and most of those plant alkaloids are metabolized by cytochrome P450 2D6. So I think it's a selection for what they're eating.
Yeah. So if someone didn't have any of the disease and they took like Benadryl or one of them on that list, would they automatically get?
You mean a prodrug?
Or just what like?
Oh, just that. Yeah, those drugs then will have, that's a good point. They will have a longer half-life in those patients.
So it'll just take way longer.
Yeah, you're gonna have to dose them down, and you might have to space doses apart in cases like that.
But would it wouldn't automatically become toxic?
Not necessarily, because some of those drugs are also metabolized by other cytochrome P450s. Yeah. Others, however, are kind of exclusively metabolized by P450 2D6. Tramadol, for example. Tramadol is pretty exclusively metabolized by 2D6. If you had a non-metabolizer, you gave them tramadol at normal doses, you'd kill them. You'd kill them. Have I convinced you this is important? Good. Yes, this is important. This is important. And even though most of you will not be prescribers, you guys may be the one to catch the drug interaction that no one else caught. And you might save someone's life because of that. And just remember, you learned it here first. Now, 2D6 is not inducible. It's not inducible. But it can be inhibited. Now, the worst ones on the inhibitors are the SSRIs, the selective serotonin reuptake inhibitors. That would be fluoxetine, paroxetine. Paroxetine in particular is a very nasty 2D6 inhibitor. And then quinidine. The heart medicine, quinidine, is also a nasty 2D6 inhibitor. One, yes. No, if someone's depressed, SSRIs are very good drugs for depression. You do need to make sure you prescribe then around them to make sure that you don't have interactions with other drugs that are metabolized by 2D6. Or if you want to use another SSRI that's not 2D6 metabolized, like citalopram or escitalopram, those tend to be 2C19 substrates. So, yeah. Now, one other drug that's a prodrug that's activated by 2D6 is tamoxifen. And tamoxifen is given for breast cancer patients. And it's well known that breast cancer patients on tamoxifen with low 2D6 activity have a high risk of relapse. So that's another drug. If you put someone on tamoxifen, you might want to determine their 2D6 activity first. Yeah. All right, question? We are zooming right through this. 2C19. On this one, I actually gave you a list of some substrates. Yeah, the drugs that are metabolized by 2C19. There are some people deficient in 2C19. 3 to 5% of all Caucasians are 2C19 deficient. Asians, however, 12 to 23% are deficient for 2C19. That's something to keep in mind. Now I have a list of the inhibitors and then another list of inducers. And in some cases, as you can see, the inhibitors may produce a condition where there's very, very little 2C19 activity at all. Probably the biggest culprit on that list would probably be cimetidine at the top there. That's a pretty powerful 2C19 inhibitor. And the other would be voriconazole at the bottom of the list. Sure, cimetidine. Cimetidine is it's available over the counter for an upset stomach. It's a histamine H2 receptor antagonist. We'll get to those. Then you have 2C19 inducers. Two C19 inducers might be the result of other enzymes being induced as well sometimes. You don't get the kind of really robust interactions with 2C19 induction that you might get with other drugs. 2C19 induction can be important. It's usually not as important as some of the others. So it's worth watching. Very good. Okay, turn the page. And now we get to 2C9. 2C9. Two C9's most famous substrate is warfarin. Warfarin. And because 2C9 is subject to genetic variation, warfarin metabolism is subject to genetic variation. And warfarin is also subject to diet as well. Ugh, the drug is a pain in the butt. Yeah.
Is that like you have to do iron
Yep. Yep. Got to get that INR checked every week. It's got to be between 2 and 3, or got to adjust the dose or whatever. What should the INR be for a normal person? No, that's for someone on warfarin.
Oh.
What should it be for a normal person? Do you know off the top of your head? I'm being mean, I know. No, lower than that.
I'm gonna go with 1 and 2.
Close, close. 0.9 to 1.3. Okay. No, no. Eliquis is a Pixaban. That's a factor 10 inhibitor. That doesn't need to be monitored. That's why people now, in fact, the big thing for warfarin was if you have artificial heart valves, you have to be on warfarin because there wasn't enough data on the new oral anticoagulants. A paper came out just last week. There was a study that looked at the new oral anticoagulants. They're actually better than warfarin for artificial heart valves. So people are trying to just get rid of warfarin because warfarin is such a pain. It's an awful, horrible pain. It's cheap. That's a big virtue, if you can use that word in the same sentence as warfarin, of warfarin, is that it is dirt cheap. You can get a month's supply of warfarin for $5. Very, very inexpensive drug. But it is an unholy pain. And some of you will work cardiology, hematology, you'll have patients on warfarin, and you'll just have days when you just want to throw that stuff in the rubbish bin. Because it's an unpredictable drug sometimes. All right. Oh, yeah. All right, so you have your inducers. Oh, well, first, there are genetic variations of 2C9. Some have greater than normal activity, some have less than normal activity, and it's distributed pretty equally amongst all the ethnic groups. Well, the genetic activity. Genetic activity. Now, with 2C9, besides warfarin, the other drugs that are of concern are the oral hypoglycemic drugs that you use for diabetes. Those drugs, if you use them with an inhibitor, you can have severe hypoglycemia. (2C9) can be induced, but its induction tends to be just a little bit. And most of the drugs you see there involved in induction are not drugs that are used all that commonly. So this is one that is not quite as important as the others. Out of those, the two, yeah, you'll probably see the most are bosentan. Bosentan is used in heart failure patients. And then carbamazepine, which is a mood stabilizer and also an anti-seizure drug. Very powerful anti-seizure drug. Carbamazepine, here's on honey. Trade name is Tegretol, but it's been in generic for years. Some people still call it Tegretol because Tegretol is easier to say than carbamazepine. All right. How are we doing? You with me? Let's do this last one. Then you can come have some of this glorious almond thing that my wife made for you guys. Believe me, it's good. I just had to have a little, and it's quite good. Now, 1A2. 1A2. 1A2 is very heavily induced by cigarette smoking. For this reason, cigarette smokers might need to be dosed up on certain drugs because their liver is in overdrive. And it's going to chew up certain drugs very extensively. Grilled meats, by that I mean burnt, really any burnt food, not just meat, burnt bread, burnt meat, grilled vegetables with all this burnt stuff on them, that induces 1A2 as well. Ciprofloxacin is a 1A2 inhibitor, but drugs metabolized by 1A2 tend to be metabolized by other enzymes as well. So its inhibition is clinically not hugely important. What is important is its induction. Okay, questions on any or all of that? Now that we've learned that, we're going to put it into practice because I have some paper. I have some case studies that include some drug-drug interactions that are caused essentially by these interactions with these different cytochrome P450s. So we have a so-called lethargic librarian, and we have stymied by statins. So these are genuine case studies from the literature, and they are based on cytochrome P450 interactions, pharmacokinetic interactions. So we'll take a break. You can come up and get as much of this as your appetite will permit, and then we will have you get into groups and work on this, work on these, okay? So let's go ahead and take a break. Please tie into, we have plates, and they're already cut, but use the spatch to distribute them. And I will pass these out. And these are...
Thank you.
Yeah.
Thank you. I know you want to. I know how to work. You know what's the what? I think so, yeah. Okay, yeah. Thank you. What is that? No, my family does eat too long again. But she's in Arizona right now. No, what is it? Oh, go ahead and get this. Thank you.
After my quiz, you guys have earned that, so.
After what?
After that quiz, you guys have earned that, so.
Oh, ER update.
So yeah, how did
So I was coming out of genetics, and then this girl was on the phone, and I had already taken her to the med stop on Sunday.
uh-huh.
And I'm like not even sure she had. No, she's showing you want to talk like where your blood vessels and where the same thing. Yeah.
Yeah.
No. So like it looked like, and so they did her hemoglobin, gave her steroids, but we had no idea what it could be. Just fix it, and but we don't have the resources to do anything. So okay, whatever. So then they called, and her hemoglobin was at 5.
Woo!
Yeah, 11. So I took her in. They and so then put an IV in, ran their lab again, and it came back at 7.8. And
That's still low.
I'm pretty sure 120 pounds. Anyways, so they had her do a fob.
Uh-huh.
Came back clear. That's really great. And then they drew for a type in screening. I didn't want to do the screening. Like, well, if you already live low, just get back on iron, get a primary at 2 years, and see if there are she had just finished menstruating too. Could already be low.
Is she an athlete?
And this girl is, well, I mean, right now she's training for a marathon. So.
And she's not eating properly.
Yep, more likely. Yeah, so that's how that worked out.
See, in a case like that, she needs to be chewed out.
Yeah, so,
She needs to be chewed out because this will have consequences later on in life.
so she's on 3 iron pills a day, at least 25 at least.
They're probably going to plug her up some beers.
She has a school doctor as well. They gave her a whole list of diets. We had to stop and get her iron cereal and jerky and stuff, more red meat. Because it's kind of served red meat hardly. You're lucky you can find it. You can get in there. So her parents are coming down next week. They're flying in and bringing her.
If she doesn't get that iron up, she should kiss that marathon goodbye.
Oh yeah, that's what I told her. I guess her iron close to the well last night. We're just gonna see what we can work with.
Well, it doesn't go up automatically.
No.
It takes a while.
Exactly. So I told her like you gotta be diligent with that diet, otherwise it's not gonna work. Right. But yeah, I was very impressed with the doctor. And they're either like either really good or they're very maybe the time of day.
Especially at Allegiant. There was a doctor there. I'm sorry. The guy was an idiot. When my wife, when she first was diagnosed with ulcerative colitis, the guy who was there he was a ding dong.
Yeah, the first guy came in and he like had this picture as to why your legs like stood all over her body. And he's like, yeah, I figured out what's going on here. And then they roomed her. And the lady that came in.
And did she have the swollen tongue and the pain on the legs? And
it just looked like big bruises. And it hurt like a bruise.
yeah.
And so the doctor said her Dittmer. Bailey Dittmer. She was from Sparrow. I think she must have been like filling in her documentation. So very professional. Like if your body is worthless, you don't have to do anything. So I was very impressed with her and how she handled the situation. So it was even rough to figure out what to do with her.
Right. So she showed a lot of compassion. That's good. That's good. Well, I hope this put the fear of God in her.
Oh, yeah. So hopefully.
See, Sydney, the other thing is I think girls today, they're under so much pressure to be skinny, to be bone skinny.
Oh, yeah.
And some women just were built that way.
No, but this is though, like she's giving around, and
I just.
It's just not to be having another one. You were right. Oh, that is good.
Yeah. Eat up. Eat up.
I got you. There we go.
I will.
What is this even made out of? She's amazing.
It's
like what's the bottom part?
flour, but it's flour. It's with powdered sugar, so it's not so dense.
It is really good.
Yeah.
Super good.
So it's a flour, but instead of granulated sugar, you use powdered sugar. That's what gives it the fluff. Yeah. Chapter 20. Yeah, the book doesn't really go into this, but you guys need to know this because this will be on the NCLEX. Maybe not in the detail I give you, but you will have drug interactions on the NCLEX. So I will make sure that you are prepared. Emily? Well, depends what I cover on Monday. Monday, I think we're going to do eyes and ears Monday.
Okay, so the quiz is usually always like what we do that.
Yeah, well, and the week before, and. Okay, folks. Now, feel free during the next period to come up and have some more. That's for you. You can have as much as you want within reason. And please now assemble yourselves into little groups of, 3, 4, 5, something like that, and discuss one of these case studies. Now, you might need to look up drugs to see what they, in fact, the handout may help you on this. So you have a librarian who has had some challenges of a psychiatric nature. And as you can see, she has OCD symptoms, which means she's probably a really good librarian. Now, they got worse, and then she was given sertraline. Sertraline, wheels start turning, SSRI. So, which SSRI, think about that, okay? Then she started, her OCD symptoms failed to respond. So something's up with the medicine, not working, something like that, blah, blah, blah. And her blood pressure, as you can see, is in the cellar, and her heart rate is 45 beats a minute. What kind of heart rate is that? That is bradycardia in the extreme. In fact, person this old, 55, 45 beats per minute, I'd be worried about her stroking out. Wouldn't you? I hope you would. So something's going on here. Figure it out. Okay, figure it out. Now, next one. Now let's do this. Let's have those whose groups are on this side of the room. Let's have you do the lethargic librarian. Let's have those groups on this side of the room. Let's have you do the stymied by statins. This one, you have a 50-year-old lady, just can't get that wretched cholesterol down, and she has depression for which she takes fluoxetine. Fluoxetine is Prozac. Prozac is a very heavily prescribed antidepressant. Very, very heavily used. In fact, it's often called in psychiatric circles, quote unquote, the happy pill, because it works really well. Now, she has a atorvastatin. But the atorvastatin, however, is giving her some side effects, bad side effects, because the atorvastatin is probably not being metabolized. Hint, hint, hint. Then we switch to simvastatin. Then we switch to something else. Well, I'll leave you to figure that out. So go ahead, get in some groups, and discuss, discuss, discuss. Go ahead. If you're doing the lethargic librarian, there's a goof. So it said a gradual dose titration of sertraline at a rate of 50 mg per month. That should be day. Sorry. Then she goes to 200 mg per day. Yeah, not per month, per day. Sorry. Antidepressants, you always start low and then you bump them up as needed. Some you're meant to bump up in order to get to a certain dose. But yeah, anyway, that's 50 per day. Okay, continue. Whoops. Well, the whole softball team now is quarantined.
Oh, really?
Yeah, I got 3 softball players in my morning class. They're all of them.
I didn't realize, I haven't heard of a lot of cases.
Yeah, and then baseball again. God. Those guys.
What are we supposed to figure out?
Supposed to figure out which drugs are interacting and why. And the enzyme involved.
Well, interacting with the Prozac because they took them together.
Why?
Well, because those are the only 2 drugs that she took, and then she had those symptoms.
Okay, what enzyme metabolizes the torvastatin?
Okay. Is it about substrate or is it on her? Another SFRI?
Well, yeah, I know. I just want you to know.
Let you know if it's on. So. Well, that's that one.
That the torvastatin is not a 2D6 substrate.
Oh, gotcha. Okay. So they're both substrates. The substrates still don't correct. And they don't.
Morgan, you have your phone? Look it up. Look it up. Look up fluoxetine. Take a look at fluoxetine. Ask what enzymes, what liver enzymes does fluoxetine inhibit?
So it's different enzymes. I don't know how to ask it. So if one enzyme metabolizes this one and one metabolizes this one, usually it's okay to take them together because
If there are different enzymes that metabolize them, yeah.
okay.
Now, fluoxetine is unusual because it's converted into a metabolite, and the metabolite actually has some activity. So if you look it up, I'm trying to get Morgan here to, you did.
What is it? 3A4
Yes, it's converted into norfluoxetine. And norfluoxetine is a 3A4 inhibitor. Norfluoxetine.
And what's the adder of the statin?
Atorvastatin is a 3A4 substrate.
So there it is. Got it. There's the answer.
And so she's experiencing rhabdomyolysis. That's a side effect of statin toxicity. In fact, I think,
So the inhibitor, so it does,
yeah.
it's the one that does the.
rhabdomyolysis. Well, no, in this case, the drug is not being degraded. So the drug builds up in concentration. That causes the toxicity, which for statins is rhabdomyolysis.
Oh, yeah. Oh, here we go. What is
See?
it? Paroxysmal.
You guys are so smart.
Paroxysmal. Yes, an inhibitor.
Now, ask yourself this. Why did this combo work, whereas that combo didn't? Morgan, look it up, look it up, look it up. Don't guess, look it up.
Our librarian friend, we recommend taking her off of Zoloft and put her on paroxetine.
That's a bad idea.
Bad idea.
This particular case study is very 2D6 dependent. Paroxetine is a potent 2D6 inhibitor.
Inhibitor increases the half-life?
The inhibitor means that the half-life of the drug is going to go way up. It's going to accumulate. So look at this. That propranolol is a beta blocker. It lowers heart rate.
Yeah.
So this looks to me like a propranolol is. Yeah. What enzyme metabolizes propranolol? Propranolol, sorry. Get the other R in there. 2D6, right? Yeah.
They're both not TC19. So she can stay on her go off.
The propranolol is lithium. When we study lithium, there's a test you give to people on lithium. You have them take a pencil and you have them just draw a spiral. When they draw their spiral, it'll be, their hand will have a tremor. Propranolol does a good job of getting rid of that tremor, because that tremor can be really annoying. Someone is, say, trying to put makeup on, can you imagine putting makeup on and doing that? It'd be impossible. You keep, right. So that's why she's on the propranolol for the lithium.
Is the tremor like akathisia? Or
No, akathisia is.
That's from antipsychotics.
Antipsychotics, yeah. Some are, for example, aripiprazole is rather notorious for causing akathisia. Yeah, that's different than tremor. Abilify, yeah, is an aripiprazole.
So you would recommend dropping completely or lowering the dose?
The sertraline?
Yeah.
The sertraline dose is the sertraline as a 2D6 inhibitor is not very strong, but the dose she's at now makes it a stronger 2D6 inhibitor. Okay. So now the propranolol is building up in concentration and it's causing her heart to beat at 45 beats per minute. That's not good. That's not good at all. So if you want an antidepressant, well, you could maybe try something like disipramine or imipramine, or you could try citalopram or escitalopram. Those are not metabolized by 2D6.
So you would want maybe something in like a TC19?
Right, just something else.
Something not in this box.
Right, something else. You guys don't have to tell me, yeah, I want this drug, just something else. Yeah. Yeah. If you were prescribers, I'd say, yeah, you better tell me what else. But you won't be prescribers, maybe you will someday. I don't know. Some of you might. So we'll just leave it at that. Yeah.
So atorvastatin, can't find on this list. And I just looked it up and I found two sites saying that Prozac and Lipitor have no, like they're it's not advised against to take together, but for some reason she's having a lot.
Well, but look at the dose of atorvastatin she's on.
50 milligrams per day.
Yeah, that's a pretty high dose.
Okay.
Well, 80 is as high as you want to go, but that's not a low dose. That's a higher dose. She's at 10 mgs, then yeah, it's not a problem. Yeah, Prozac, that's a pretty hefty dose. Now, fluoxetine is converted into a metabolite. What metabolite is it turned into?
But it's
It's turned into norfluoxetine. And norfluoxetine is a 3A4 inhibitor. Pretty potent one too. This is a 3A4 substrate, so is simvastatin. Pravastatin is not.
okay. So Lipitor is a 3A4
3A4 substrate, yeah. So this is inhibiting that. The symptoms she has, that's rhabdomyolysis. All her muscle fatigue, that's rhabdomyolysis. Destruction of the muscle.
I'm sure I would have gotten there eventually with that med term. We just took a med term class, so I was like
okay.
trying to put it through my brain.
Okay. Well, you could see simvastatin, that's in the same class of drugs as atorvastatin, that causes rhabdomyolysis and this toxicity. That's what this looks like. Looks like that. Looks like this.
Okay. That makes sense.
Okay.
So, because 3A4 metabolizes Lipitor, correct?
Yep.
But then the fluoxetine
Right.
isn't
Turns
enabling that
into
to happen.
is metabolized to norfluoxetine, which is a 3A4 inhibitor.
Okay.
So now the statin rises.
Okay. Okay, got it.
And citalopram, that's not a 3A4 substrate.
Okay.
That's different.
Pravastatin isn't a 3A4 substrate.
No, pravastatin is totally metabolized by phase 2 reactions.
Okay.
It's not metabolized at all by phase 1 reactions.
Okay. Got it. That helps a lot.
And it worked. It lowered her cholesterol. Still a little high, but you can live with that better than 290s. Figure it out?
I think
Yeah, no, Allison's right. Together can increase the effect. Allison, what do you mean by increase the effects?
like cause dizziness and like potentiation.
That's more pharmacodynamic interaction. This is a pharmacokinetic interaction.
So
What's happening here is that at the dose of sertraline she's at, it's inhibiting CYP2D6, and propranolol is a 2D6 substrate. So your propranolol is accumulating, and it's causing her heart to beat really slowly and dropping her blood pressure in the cellar. No wonder she's passing out.
wait, the sertraline is?
Yeah, sertraline, it is a weak 2D6 inhibitor, but at that dose, 200, it's going to inhibit 2D6 pretty robustly.
So the high dose is
Yeah. And so propranolol, so lithium, if someone's on lithium, there's a easy test you give. You have them just do this. If they get the tremor, that's a common side effect with lithium, is a tremor. There, it'll look like this. It's really easy to tell. Now that tremor, fine tremor, is really annoying. Imagine trying to put makeup on with that kind of tremor. You take your eye out. Propranolol does a really good job of getting rid of the tremor.
So does it
It just decreases the It's a sympathoplegic type of drug, and that sympathoplegic activity decreases the tremor so that you don't have it anymore.
So is that why too much of it makes your pulse and your blood pressure?
Right, because it's a beta blocker.
Okay.
It inhibits beta adrenergic receptors in the heart, so the heart can't be stimulated by epinephrine or norepinephrine.
So they're taking 20 milligrams of that 3 times a day.
Yeah, that's a low dose propranolol. Yeah. Propranolol is a short half-life drug. Some performers will take it for stage fright because it's very good at just calming you down, making everything.
So is that technically like a scheduled drug then? Like is it
No,
or
no. You have to have a prescription for it, but it's not scheduled. 20 mgs is a low dose. So you're just taking it often to make sure. And the blood pressure reduction she's probably getting is not that big. But then you put in with that sertraline, now propranolol starts to climb. It's no wonder she wasn't falling asleep at the desk, much less getting up.
yeah.
Her blood pressure is 75, good gravy. So she needs to get off the sertraline. There are other drugs you can use for depression. She can use a tricyclic, she can use imipramine, desipramine, amitriptyline. She can use citalopram, escitalopram. There are other options.
Wait, so why is propranolol, indorol accumulating in the blood?
Propranolol,
Yeah.
because the enzyme that degrades it,
Is being used.
cytochrome P450-2D6 is being inhibited. SSRIs inhibit 2D6 typically. Of those, paroxetine is the worst, then followed by fluoxetine. Sertraline is not that bad of an inhibitor, but when you get to high dose, it's dose dependent, inhibitor of 2D6. When you get to the top of the dose, you're inhibiting 2D6. Your 2D6 activity goes away. That's why you're getting that effect. Okay? Okay, you guys know what's going on?
Yeah.
You got it? Yeah, okay. You guys done? You're done? Okay, and okay, you guys done? All right. Hey, let's have a rep from each group talk about the fruits of your labor. Let's start over here. We'll go this way and this way, this way, this way. So we'll do a little spiral here. Just pick somebody or somebody can volunteer if they like to talk. And they can tell the class what they discovered. So you all over here, you guys go first. Go ahead. Somebody, anybody. Or a different antidepressant in general, which that would be for her psychiatrist to figure out. Or perhaps if you're maybe a psych nurse, maybe you're a nurse practitioner with specialized in psych, then you might prescribe it. Okay. All right, you all. And you agree with their assessment of what's going on? Okay. Now, we'll see this with lithium. With lithium, you get a fine tremor. And propranolol is one of the drugs that takes away that tremor. And it's very good at that. That's why it's commonly used with people who take lithium. And lithium is the drug of choice for maintenance treatment of bipolar disorder. Did you guys read in the paper, there was that chap, he plays football for I don't know who, but he wailed on his girlfriend, and turns out he was bipolar and he was off his meds. Did you guys hear about that? No. He wailed on his girl. He beat the crap out of her. I mean, the pictures are hard to look at. And he told her, you need to bow to me. And she said, I need to what? Forget you. And he whooped her. I mean, he really beat the tar out of her. So he's in prison now, but turns out he was bipolar. He was off his meds. I say this is not something to screw with. Bipolar people can become violent. They get off their medicine. They need to be treated. They need to be treated regularly. Taking medicine is not an option. Bipolar people can do really crazy things when they're manic. So this is a big deal. Okay, you all, our statin group, go ahead and tell us what you found.
Okay, so we found that atorvastatin, 3A4 is the enzyme that metabolizes it, and she took it with fluoxetine, which is an A4 inhibitor. So the fluoxetine was inhibited.
Fluoxetine. Thank you.
Was inhibiting the 3A4 to then the atorvastatin was getting metabolized.
And it caused what kind of condition did it cause? Morgan, what's it called? What's the word we used? Rhabdo what? It's, yeah, rhabdomyolysis. Rhabdomyolysis. That is a toxicity with statins if their concentration gets too high. Okay, do you guys have anything to add to that?
Not really. They kind of got it, and the only reason the Flexa and Tabasco works is because Flexa isn't, it's not metabolized by 3A4, and then Tabasco isn't a 3A4 inhibitor, so they work together.
Very good. Very good. Okay, yeah. Yes. Yeah. Seahawks released him. Yeah. This was pretty recent, and guys, don't look this up. The pictures of what he did to her are hard to look at. He beat the heck out of her. No. Yeah, no, it's bad. It's bad. So, all right, now let's we've got 7 minutes. Let's talk about one other type of drug interaction. All right, good job, everyone. Now, those types of drug interactions are pharmacokinetic. Drug-drug interactions. They have nothing to do with the activity of the drug. Instead, this is wholly a function of the way your body treats the drug. And I think you saw that in those case studies. And I think the case study, I saw a lot of lights go on with the case study when you saw it applied to a real life situation. It becomes more real, and you see, yeah, this is important. This is important for patients. Now, there are also pharmacodynamic drug-drug interactions. And these have to do with the mechanism of the drug. Let me give you one example of a pharmacodynamic drug-drug interaction that's actually more common than you wish it would be. So, some of you are familiar with donepezil. donepezil. Donepezil is used for people who are either, they have Alzheimer's or they have dementia or something like that. And you usually have some sort of decrease in cognitive ability. That decrease in cognitive ability so this is an inhibitor of acetylcholine esterase. So acetylcholine esterase takes acetylcholine and it degrades it to acetate and choline. This is an important neurotransmitter, is it not? Yep, this binds to muscarinic receptors. In the brain. It's important for learning, memory. By inhibiting this enzyme, cholinesterase inhibitor, you increase the concentration of this. You increase the concentration of this in the brain and you increase cognitive ability. But there's a problem with this drug, and that is some people will experience urinary incontinence. And you might think about why this is the case. And why it's the case is that the detrusor muscle of the bladder has muscarinic receptors in it. So bladder, the detrusor muscle, it has these M3 receptors. So what does somebody do if they have urinary incontinence? They go to the doctor. They don't tell them they're on donepezil, and they get oxybutynin. Why would they give them oxybutynin? Cheapest chips, old drug, and it works. Takes care of the urinary incontinence, but this drug is very lipid soluble. If it's lipid soluble, where's it going to end up? In the brain. And now she's taking this to increase cognitive function. But now this drug goes to the brain and it inhibits those muscarinic receptors in the brain. What's going to happen to her cognitive ability? It's going to tank. And the doctor has no idea she's on oxybutynin. No one can figure out why her cognition has gone south. So what do they think? Oh, her Alzheimer's really bad. We need to put her in a home. It's bad. She's going downhill so fast. When? It's a drug-drug interaction. If someone had just told somebody that she was on this drug, they'd figure this out. This happens a lot. And the sad thing is, this is avoidable because there are drugs for urinary incontinence that don't go into the brain that you could have used. They're more expensive, but because we're going for, cheap and available and works, that's what we end up with. So, bottom line here, get your patient to tell them everything they're on. Everything they're on. This is a pharmacodynamic drug-drug interaction because it has to do with the mechanism of the drug. Okay? That's just one example. There are lots of others, but we'll cover them. Okay, Monday, eyes and ears, glaucoma and eye infections and all that good
I
stuff.
got like both.
Yeah,
So I think I got lost when we went over to the muscular, whatever is up there.
right. So acetylcholine,
The Donepezil,
donepezil,
yep, and that's for her, like,
cognition.
right. And it's the acetylcholinesterase inhibitor,
Yeah,
but that causes urinary incontinence.
right. It increases cognition, but it does so at a risk of causing some urinary incontinence. Actually, only about 7% of
Okay.
people on this drug get urinary incontinence, but it can be really annoying
Right.
and embarrassing.
Right.
So they go to the roadside clinic
Yeah.
and the doctor says, oh, we can fix that. And because you're on Medicare, this will be paid for.
Right.
Yeah,
Okay, so I get that side of the board. I'm a little lost on that side. I don't know what's happening. So I get that it's lipid soluble and then it goes to the brain.
right. It gets in the brain, penetrates the blood-brain barrier. Now, these muscarinic receptors that are receiving large amounts of acetylcholine, they're being inhibited. This is an inhibitor of muscarinic receptors. By inhibiting this receptor, it decreases the tendency to
Control it.
right. Now it's not so twitchy.
Right, okay, so,
So you're negating the effect of this drug by the oxybutynin entering the brain.
okay, thank you.
And there are other drugs for that that do about the same thing, but yeah. So there's oxybutynin, there's solifocin, that's just as bad as oxybutynin. There are alternatives. There's darfenicin, solifenicin, much better
Okay,
alternatives, but they're more expensive. The best one is mirabagon, which is a beta-3 agonist, which we'll talk about later. Yes, ma'am.
so I just had a question on, like, the one case study, the librarian.
Yeah.
So, I guess I wasn't really understanding, so she was on Indorol and Zoloft. So we were saying like,
Well, she's also on lithium.
and lithium.
Yeah.